Hi, Dr. Laura. It's my pleasure and privilege to welcome you to MVR Cancer Centre. I hope this is your first visit to Kerala. How do you find Kerala?
Kerala is absolutely stunning, really beautiful, so green, and it's an absolute privilege to be shown around the place.
What about our campus?
I found it absolutely delightful. I had such a warm welcome. I was shown around the atrium, which is light and airy, beautiful plants, and a very relaxing experience.
We believe that for treating cancer, the environment should be also very good for or contributing for the better outcome of the treatment.
Yeah, I can't argue with that.
We don't know how long we will be able to maintain this greenery, but this is very essential. That is what we believe. Okay, anyway, welcome to our campus once more. You are working as a consultant in UK for the last 10 years.
A consultant for 11 years, but
11 years, yeah.
Medical school was in the 1990s.
Oh, yeah. It's a pretty long experience treating breast cancers. So in India, we find a lot of issues in the management of breast cancer because we get patients at a much more advanced stage. Like when we were doing our post-graduation, about 70 to 75% of our breast cancer patients come in stage 4. A lot of awareness has been created, and as a result, right now we see majority of patients in stage 2 and stage 3. But still it is in the advanced stage. I'm sure you will be seeing a lot of patients in very early stage, like only mammographic abnormality or not even stage 1. So what is your experience?
That's right. So really, as we all know, the earlier you detect cancer, the better the outcomes. And we've got a screening program at home, which takes women that are usually between the ages of 50 to 70 and screens them with mammograms. So we can pick up their earlier, smaller tumours, and we can pick up, as you said, not even stage 1. So we pick up DCIS or ductal carcinoma in situ at that earlier stage. And we can expand the screening age depending on patients' risk factors. So if you find someone at higher risk due to genetics, for example, you can start their screening process earlier. The other thing that we have at home, as you've clearly got here as well, is an awareness campaign. So we have a lot of awareness that's taught from a young age. We have awareness that's advertised in our general practice, that's through charities. So we really do tell patients, the population, not patients, as early on as possible, check your breasts, make sure you're examining them regularly, and these are the signs to look out for. So a lump or a change in the appearance of the breast, for example. And if patients develop that, they go straight through GP, it is in England, and then through to the breast unit where they'll have a triple assessment.
So you start from the college or even school days,
yes.
and give wide publicity and all something like very structured screening programs to get or continuing in medical insurance. One has to do the screening yearly, and so that's a very nice thing. And in India, we have about 1,500,000 total breast cancer cases diagnosed per year, and which constitutes about 15% of all malignancies. But in Kerala, we have the 3 times more of breast cancer compared to the rest of India because of the lifestyle changes and the aging population and all other risk factors like the hormonal changes, everything. And we do see a lot of children getting menarche early, and there is a delayed menopause in the women of 40s and 50s. But when you consider the breast cancer profile, the Indian patients generally have a poor outcome. That is what we believe. The reason being, we see a lot of triple negative breast cancers compared to the West. That is one reason. And we see a lot of patients coming in the advanced stage. That is also contributing. So 15% of all malignancies, when it comes to Kerala, if you look at the incidence, it is 47 cases per 100,000 women. So that is something, it's almost 3 times of what we see in the rest of India. Then there is a problem of out-of-pocket expenditure. So we cannot assure that we are giving, all patients are getting equal treatment. So these are some of the issues. I'm sure even in your country also there will these kind of problems will be there.
Yes.
But certain problems can be addressed in a proper way, then we can reduce it. So considering this TNBC, what is your incidence in this highly aggressive group of breast cancer?
So roughly in the UK it would be about 70% or so ER positive, HER2 negative, roughly 15 triple negative, roughly 15 HER2 positive. So that's our general makeup.
So most of them are hormone receptor
positive.
Positive. Okay. So again, coming back to the treatment cost, you have a very beautiful program there. The NHS is doing wonders there. But I'm sure all these newer anti-HER2 antibodies and as well as the immunotherapies, are they approved by NHS, and are you able to offer to all patients, all needy patients?
So the NHS has got a lot of very good points, but it's also got a lot of challenges. So the demand for our services is up here, but our capacity is down here. And we have a big problem with retention and recruitment of doctors now. In terms of funding for all of these new drugs, there's never been a more exciting time to treat breast cancer, but at the same time, it's so challenging. So yes, when there's a new drug, NICE, or the National Institute of Clinical Excellence at home, will evaluate it to see whether it's willing to fund it or not. We have a program called the Cancer Drugs Fund, or CDF, and the vast majority of our drugs are going through that. So that will still be funded so the patient can still access them as long as the government have essentially granted that that's okay. What that means for the patient is they get the drug, that's grand. What it means for the doctor is an awful lot more work in terms of who is actually eligible. We're very restricted on what we can and can't use, and an awful lot more paperwork, of course. But we're in a situation right now within the UK where, for example, HER2 low, which is another entire subtype which has come to complicate matters even more. If patients are in Scotland, for example, they're able to access Enhertu. If in the HER2 low setting, in England, they cannot in the HER2 low setting. At the moment, it's only for the HER2 enriched or HER2 positive. So there is some discrepancy still. So we have some challenges.
So this Enhertu is not widely prescribed?
For HER2 low. For HER2 enriched, HER2 positive, it is available through the Cancer Drugs Fund for any NHS patient.
I still remember the approval of Avastin got delayed several months. One of the problems in India, our patients follow up some of the centers, and we have about more than 90% regular follow-ups. So they keep coming for the follow-up on time. But this is not the scenario in many other institutions. So what is the follow-up, the adherence to the follow-up rate in UK?
In terms of adherence to hormones?
In terms of the post-treatment follow-ups, and how regular are they?
So typically, once we've finished all of our adjuvant treatment and the patient's been seen post-radiotherapy, if they're receiving adjuvant bisphosphonates, they'd receive that in the unit. Once they're settled on it, we wouldn't bring them back to clinic to see us in oncology. What we would do is discharge them to something we call the stratified surgical follow-up. So the surgeons will do their mammogram once every 12 months for the first 5 years, and thereafter they'd return to the 3-yearly screening program. But the patient would have open access. So if the patient notices any problem, either themselves with the breast, or they're worried about some other aspects, so they've developed back pain or headaches, for example, or they've got an issue with their hormone therapy, they can contact their nurse specialist team who works with the consultant and says, immediately, I've noticed this problem, what shall I do? And then the specialist nurse will be able to say, this is for your GP, or here's some advice, or actually you need to come back to be fully evaluated. So that open access is there. Because what we've found is there's been so many people diagnosed that we simply don't have the capacity to review them once a year, or so we're reviewing them when they need to be reviewed with a symptom or issue.
So what about the generics? You have generics medicines as well, because many drugs are very costly and many molecules are very costly. So in India, we get a lot of generics, and that's how we maintain we are able to give a reasonable care to our patients. What about UK? The generics are commonly used there? Or?
So, once something's come off patent, that's fine. But otherwise, we tend to use the standardised molecule. What we do have is biosimilars. So, for example, we used to use trastuzumab as Herceptin, but now we can use a biosimilar called Hazuma, and there are various other biosimilars. And typically, it would be the one that's the most cost effective, because the NHS is very much into saving money, like everyone is.
Oh, that's a good thing. All patients in our country, especially in this part of the country, are reasonably aware of the management protocol. And generally they do second opinion, third opinion, and so on. In a system like NHS, how often they take second opinion? Are they permitted to take second opinion or the third opinion?
It would be extremely rare, actually, that patients take a second opinion. So it could be done in one of two ways. If you felt that you wanted a second opinion because it was such a complex case, you of course are very welcome to do that, but that's a very rare, because we work in such big teams in the MDTs. If the patient wished for a second opinion, they are entitled to ask for that from you as the oncologist or through their general practitioner, and then that would be done for them. But they, by and large, there is a reason why they would want. There has to be a good reason for them to want that. Through the NHS. So they are permitted, but it's a rare thing.
So what about the clinical trials? You put them on clinical trials, a good number of patients will be put on.
Yeah. So, I believe, as I'm sure you do, that it's only through participation in clinical trials that we're able to progress and drive up standards. So we're very passionate about clinical trials. So ideally, any patient you see should have the option, but that's not always appropriate. There's not always the right trial. So if you have a trial, of course, they would be offered. If you didn't have a trial within your own centre, we do work collaboratively within our region and within the country. So if I know there's only one hospital that's offering a particular trial, then I would, of course, send them for that trial. So it should be collaborative working.
We are one of the large volume centers in terms of breast cancer. We get about 1,400 patients treated per year in this institution alone. And we try to give equal care to all patients, irrespective of their financial strata. But still, we find a lot of challenges in following the equity in cancer care. But by and large, all patients are treated according to the guidelines, standard guidelines. And if they are not able to, if we are not able to give them that care, then we will send them to a government center where they get similar care. You have just seen our setup. How do you feel? How the standard of care in terms of facilities, what do you think MVR has got?
I'm blown away by the standard of care that I've seen. Throughout a lot of India that I've seen. Obviously, it's an extremely large place. But in terms of facilities, I know you have virtually no waiting list. So if a patient needs something, they're getting it practically immediately. Which is something that I'm very envious of, because we have waiting lists in the UK. If you need some imaging for a patient, you can have it straight away. And again, we have restrictions on some things like PET scanning, for example. There's set guidelines on when you can and can't use that. Whereas here, if you feel it's needed clinically, you can have it. That is phenomenal. So I think patients here are extremely fortunate that they've got access to this sort of immediate resource. So again, as I said earlier, the earlier you catch the cancer, the better. but also the earlier you treat the cancer, the better, which you're able to do a lot faster than we are in the National Health Service at the moment.
Well, thank you so much for spending this much time. It's a real pleasure talking to you. I hope you will come again visiting our campus and collaborating with us in future also. Thank you.
Thank you very much. Thanks for your welcome. Thank you.